Okay, so let me ask you, if you do need a transplant, and it sounds like you still see some role for this.
At this point I do.
You know, I've heard people say that these new drugs are not imatinib, not at least at this point. What's the latest in terms of transplants? And I'm particularly interested in the radioimmunotherapy kinds of approaches with CLL. Those seem like they would make a lot of sense, but I know that they've been kind of futzing around with trying to get the right protocols for CLL.
Sure. You know, I think the data in transplant and CLL is not nearly as widely known or accepted as it should be. It's clear that transplants for patients with CLL can be curative. We have many patients that we've got out many, many years without any relapse. And frankly, if you get out 3 years after a reduced intensity transplant for CLL, you're not going to relapse. It's
3 years?
Yeah, 3 years. You're not going to relapse. The chance of relapse is exceedingly small after 3 years. In fact, in some settings, perhaps close to zero. Of course, it takes a while to get to the 3 years, and that's a challenge in many patients. And transplant's not for everyone, but clearly we know that many people can do very well. Perhaps they're a little younger patients who are more motivated to do something like that. Sometimes people who have had shorter remissions. And what we've learned is that there are some people who do particularly well, and some people who don't do as well that we need to, of course, continue to improve on. The people who do great typically are the ones with the lower disease burden, perhaps don't have a 17P, don't have 11Q, don't have those worse factors. They're mutated immunoglobulin heavy chain variable region. You get the idea. Of course, not surprising, they do better with transplant as well. The problem is that most people end up getting to transplant now have evolved to have many of those poor prognostic factors. So that's where perhaps combining the reduced intensity transplant to develop a graft versus leukemia effect, or you could call it a graft versus lymphoma effect depending on how you look at the CLL, but that type of transplant, to get that, really needs to have some good disease control in those bad patients going into the transplant. And that's perhaps where a radiolabeled antibody, or maybe something like Zevalin as up front of the reduced intensity transplant, makes a lot of sense. And it turns out that we've actually done this, others have done this, for let's say a patient with bulky CLL. They do much better if we can get their disease reduced with the radiolabeled antibody, maybe something like Zevalin, and then get them to where we can generate that graft versus lymphoma effect or graft versus leukemia effect over time to get them to eradicate their disease and do it hopefully relatively safely. And that's where transplants have really evolved as well. Certainly graft versus host disease is not uncommon, but managing it, dealing with it, we're much better with that. And there is morbidity, but often it's not nearly as bad as it has been in the past. So I think transplants are not for everybody, but clearly they're important for many patients and something for people to consider. I will also say not only just using standard doses of radiolabeled antibody like Zevalin up front. In Seattle, we've been using escalated, very high doses of radiolabeled antibody up front of transplant for patients like this. And we've seen that the higher the dose we can deliver, probably the better chance we have to get patients excuse me, into a really good spot going into the transplant, and that these targeted deliveries of radiation in the CLL patient associated with the transplant probably doesn't increase the toxicity any appreciable degree. So I think radiolabeled antibodies do have a role in transplant for patients with CLL.